All right, welcome everybody. We've got a couple more people that are still battling raindrops on their way here, taking their time, being safe, and they'll be here shortly. We have others who are participating and are watching on Zoom, so welcome those of you out there in Cyberland who are watching online. My name is Jason Peterson. I'll be the moderator for the Medicaid Client Voice Council October meeting. Welcome. Thank you all for being here, getting here safely. For 6 of our members who started 2 years ago, this will be their final meeting. And so a bittersweet day for them. We'll have some cheesecake. We'll have an opportunity for them to share some things, some thoughts that they have, maybe a little slideshow. So we look forward to that. We've got a couple of presentations. Then we're going to talk about MAC proposals, how we can, we're going to talk about that process, about what we're going to propose later in the day. But before we get going, let me get my wireless. The secretary had other business. She could not be here. She wishes you well, of course, wishes she could. In lieu of that, I'm going to let our chairperson, Brandy, and our vice chairperson, Jennifer, offer a few words before we get going.
Thank you. Just wanted to welcome everyone to our final Medicaid Client Voice Council meeting of the year. Wanted to thank everyone for the insight that you've shared throughout the year to strengthen the voices of those that we serve. Hopefully we can make this a very meaningful and productive closing session.
All right, and thank you for your service. And Jennifer, our next year's chairperson.
Hey. I just want to say I'm glad everybody made it here safely. There was a bad wreck, so and I've enjoyed getting to know Brandy and being involved in this council. I think that we can definitely make a difference in the lives of the Medicaid clients.
All right, thank you. And for those of you watching online at home, we're having Chick-fil-A for lunch. Sorry you can't be here for that. It's going to be good. We are still awaiting a couple members who should be here shortly, but we need to get going. We've got a lot to do today. We're going to start with Medicaid renewals. Division of County Operations Director Mary Franklin is here to share a presentation on the Medicaid renewal process. This is something that has come up continually through our existence, just the whole notification process, how these things work. She's going to shed some light on that. She'll also offer a sneak peek at some notice changes that are on the way, including the use of QR codes. Mary can answer questions about email notification, alerts, other aspects of the renewal process. So without further ado, let's welcome Mary Franklin to the podium.
Good morning, everyone. Can you hear me okay? All right. It's good to see you all today on this rainy day. All right, we have put together a presentation, just a high-level overview on the Medicaid renewal process, and we'll be happy to answer questions because, this is not likely to answer all your questions, but it may actually help you think about questions you want to ask. So right now the renewals are required annually. And I've got a little note there, a little asterisk, because effective January 1st of 2027, the Our Home category will be required to be renewed every 6 months instead of once a year. And that is a change that came with the HR 1 or One Big Beautiful Act. And so this is effective across the board, across the country for Our Home. But all other categories, the renewal schedule continues to be annually. Our first step in the renewal process, no matter what your category is we try to do a renewal ex parte. And what that means is we try to renew everyone using our data sources and what we know about the individual in our system, and see if we have enough information to complete that renewal without having to ask our client to fill out paperwork or provide information. So that's always step one. If the ex parte process is successful, we renew the client, reset the Medicaid certification period, and then we send a notice that says, we've completed your renewal based on this household size and this income information. please let us know if anything has changed within 10 days, because Medicaid does have a 10-day reporting requirement for any changes. If the ex parte process is not successful, then we mail a pre-populated renewal form. And pre-populated just means it will have your name, address filled in, the household members, what we know about your income, assets, if it matters in your category. Basically, everything that we know that we have in the system is already pre-printed on that form, so that all you have to do if you need to complete a form is tell us what changed, right? There's a space for telling us when something has changed. So we send those forms by mail unless someone has opted into electronic notices, and then what we do is send an email or a text alert that says, hey, you have a document ready to review. Please log into your account and do it there. But the point I wanted to make there is, even if we mail you the form, you can still go online at Access Arkansas and turn it in. You can complete your renewal online. You can turn that form in person in an office, or mail it or fax it to us. And you can also complete a Medicaid renewal over the phone at our toll-free number, which is on here, 855-372-1084. Now I want to walk you through the timelines for renewals for our MAGI Medicaid categories. And you guys have probably heard me talk about MAGI before, but MAGI means Modified Adjusted Gross Income. That's what MAGI stands for in the Medicaid context. And that is the income methodology that we use to determine eligibility for the MAGI categories. And our MAGI categories are the Our Home group, pregnant women, the unborn pregnant women group, the parent caretaker relative, the former foster care, Our Kids A and B, and newborns. All of those are MAGI categories, and that income methodology was set by the Affordable Care Act, which is 11 years ago now, I think, that went into effect. And but for those categories, we start the renewal process 2 months before the end of the certification period, so about 90 days prior to the end of the certifications, actually a little bit more than 2 months. If we do successful ex parte, there's no further action needed from the client. We mail a renewal notice showing the coverage is renewed in the new certification period. If it's unsuccessful, we mail the pre-populated packet about 80 days before that renewal is actually due. Our initial due date is the 10th of the month prior to the month the certification period ends. And then if the renewal is not received on the 15th of the month prior to the end of the certification period, then we send a reminder, and we send an advance notice of closure 35 days before the case actually closes. So we start trying to do ex parte, and then we mail a form. It allows 30 days to turn it in. If we don't receive it, we send a reminder and a closure notice. And this is an example. It always helps me to put some dates with an example. So this is an example. If someone has an Our Home certification period, October 1st, 2025 through September 30th of 2026. We're going to start the ex parte process around July the 1st of 2026. If it's successful, the renewal is complete, no further action needed. If the ex parte is not successful, then we send a renewal packet. We send that about July the 10th, and the due date's going to be August the 10th. And on August the 15th, if we haven't received that packet, we are going to send a reminder. And then on August the 26th, if we still haven't received that packet, we're sending an advance notice 35 days ahead of the closure, which will happen. The last day of coverage would be September 30th, so the first day without coverage would be October the 1st. And there's just also a note here, a reminder that individuals can opt in to receive email and text alert notifications. And you can also have letters mailed to authorized representatives if you choose to. Now, this is a look at the renewal timeline for our ABD categories, age, blind, disabled, and long-term service and supports. Those categories include nursing facility coverage, living choices, AR choices, TEPFRA, autism, DDS waiver, PACE, the Medicare Savings Program, PICKLE, disabled adult child, COBRA, OBRA, all the OBRAs, and medically needy. We start those even earlier than we do the MAGI categories because there's more involved in completing a renewal for these categories than the MAGI categories. So we start those about 120 days before the Medicaid certification period ends, and we also start with ex parte, yes, even with the aged, disabled, and LTSS categories. If we are able to do ex parte, then we do that, and we send a notice letting our client know that it was renewed and to report changes within 10 days. If the ex parte process is not successful, then we mail a packet, pre-populated again, and that packet goes out about 110 days before the end of the certification period. We send a reminder letter on the 15th of the month prior to the month the certification ends, and then we send a closure notice 35 days ahead of that closure if we don't get the packet back. And here's an example with dates. So we have an AR Choices client whose certification period is October 1st of 25 through September 30th of 26. We're going to initiate the ex parte process around June the 1st in this example. If it's successful, we're done. We send a notice to the client. No further action needed from the client unless they have a change to report. If the ex parte is unsuccessful, then we're going to mail a pre-populated packet around June the 10th. We're going to give them to August the 10th, so longer to get that packet completed and sent back to us. And then on August the 15th, we're going to send a reminder notice if we haven't received that packet, and we're going to send an advance notice of closure on August the 26th for the case to close, with the last day of coverage being September 30th. There are grace periods related to renewals. So if you miss that window, if someone doesn't turn in the packet, and this is for the MAGI group, if the renewal form or information is provided late, but prior to the end of the certification period, we're going to leave the coverage open. So, while we process the renewal. So here's an example. If the certification period ended September 30th, and we got the renewal form, we asked for it back by August the 10th, and the renewal was provided on September the 20th. Well, it's still within the certification period, so we're not going to close that case September 30th. We're going to keep the case open while we process the renewal to determine if the client's still eligible. If the form is turned in after that certification period ends, after that closure, in MAGI, clients have 90-day grace period to get all the information we needed returned, and we will determine eligibility, and if eligible, we will reinstate that coverage so that there's actually no break in the coverage. And here's an example with dates. This example, the certification ended August 10th, well, September 30th. The renewal due date was August 10th. The renewal was provided on December 7th. And the coverage ended as of October 1st, but the renewal is still going to be accepted and processed, and coverage will be reinstated back to October 1st, even though that renewal form didn't come in until December the 7th. As long as the client is determined eligible. So there's a grace period of 90 days for MAGI categories. There is a shorter grace period for age, disabled, and LTSS categories. And again, if the renewal form is received late after the due date we gave, but before the coverage actually ends, we're going to keep the case open while we process that renewal. And so an example of that, if it's a certification that ended September 30th, the renewal was due to us by August 10th. The form was provided on the September the 20th. Well, we're going to keep the case open while we process that renewal. If the form is received up to 30 days after the case closes, then we will still process the form, still redetermine eligibility, and reinstate the coverage back to the date that the coverage was lost, assuming that they are still eligible. And an example of that would be, again, the certification period ended September 30th. The form was due August 10th. The form was returned to us on October the 7th, which is after the end of the certification period, but less than 30 days late. We're going to process that renewal and restart coverage effective October 1st, as long as the client's still eligible. So in our age disabled categories, our LTSS group, disability rules, they vary across the Medicaid programs. Disability and the type of disability if it's a category that requires a disability status, then we determine disability based on Social Security. If Social Security has determined someone disabled, we follow that determination. We accept it. Railroad retirement, Veterans Affairs, or the DHS medical review team. If it's a category that requires disability and it's someone who's applying, maybe they're newly disabled and they haven't actually been through the disability determination process with Social Security or any of these other entities, we are going to collect information, collect medical records, and then determine whether someone meets the disability requirement based on the same rules that Social Security uses. But we will do that in-house. When it's a category that requires disability, that disability determination, if it's done by medical review team, is either going to have it's going to be good for a year without review, or 3 years, 5 years, or could be permanent. And if someone is determined disabled by one of these other organizations, Social Security, Railroad Retirement, VA, then as long as that organization continues the disability, then we accept it. And so the length of time that the medical review team would assign to a disability really depends on the type of medical condition and the information that's causing the disability and the likelihood of it improving. And and I want to make the point here that disability is not the same thing as functional medical needs. Those are two different things, but some of the categories require both disability and a functional need high enough for coverage in the category. And an example of that AR Choices is one example, because AR Choices covers adults ages 19 and up, right? But if you're under 65, then you have to be disabled to get into the category. Not only do you have to be disabled, meet the financial requirements, you also have to have functional needs in addition to the disability that would require the level of care similar to a nursing facility. Now we'll move on to the level of care, the medical needs. Those requirements also vary across programs. And if it's a category group that requires a functional need, that functional need has to be reevaluated every year. Just like the financial side has to be evaluated every year, the functional needs side has to be evaluated every year. But if disability is a requirement, it may or may not have to be reevaluated every year. It just depends on who made the determination and what the medical condition is and the likelihood of it improving. But some of the categories require a form to be completed by a physician as part of the medical needs determination process, such as TEFRA. That requires a form at this point to be completed by a physician. And others may be done through like an in-home visit from one of our DHS nurses that do a functional needs assessment, and then could even potentially, depending on the outcome of that assessment, also include an independent assessment from our independent assessment provider. All right, I'm going to stop there in case you have questions about renewals before we take a sneak peek at notice changes and talk about notices.
Any questions about renewals, and also for our folks who are watching online, you can type in your question, or we do have the ability to listen to you if you want to verbalize your question. Just we're monitoring it, so I'll be notified if there's a question in the chat on Zoom.
Mary, I know we talked in there when you did the demo for us about the role of the care coordinator and if they could serve as an authorized representative. I just wondered, as you were talking about the authorized representative, they could get a letter. It would be very helpful if the care coordinators would be able to get one. But did we decide on, is that a conflict of interest, or can they be an authorized representative? I think on the demo you said they could help, but I'm just asking on the behalf of, I think it'd be very helpful if they were able to get that letter to keep the member eligible.
So I believe that there are rules, I'm looking at Elizabeth to make sure I get this right. There are rules about managed care being able to be authorized representatives. There are some rules outside of DHS rules that preclude that, I believe. But care coordination is different, and being a community partner is different, yes.
Yeah, for the past team, they've always assisted with beneficiaries with the renewals, but they can't be like the caller, right? They can't be the one who completes everything. But I mean, what we've instructed them to do before is remind. They could go with their cell phones and, be with the person while they call. So those are all those kinds of support things that our care coordinators do.
Right. Very similar to community partner. And many of our past employees are community partners. But that is a different status than being an authorized representative and being legally responsible for the information provided. But we can take that back and confirm that.
The letters, right? I think they can only help and assist. That's what we did.
Yeah.
I'm just wondering about that letter notification, especially for people that don't have natural support.
One of our Zoom participants has a question. Let's see. All right, and this is Angelica. Can we submit renewals through the county email?
Yes. Yes, we accept renewals by email, by phone, paper, mail, online.
And I know that Angelica had proposed that county emails be added to notices, but you are moving away from that to be more of a universal approach using,
Right.
You're going to talk about QR codes. I don't want to get ahead of your presentation, but we'll get to that in a moment.
Sure.
Okay. Brandy had a question, and then Catherine has a question.
When you're talking about the care partners, community care partners, so something that's been brought up to me has been the long-term care facilities, like business office managers that assist their residents with applications. Do they get like a master list of everyone that's in their facility? Do they, is there a way that they can be notified or are kept abreast of that information for renewal processes? I know that a lot of them kind of keep their own spreadsheets that they've made themselves just to kind of keep up with this is when we applied, this is when we should be seeing a renewal come up. But is there any official notification that they get as a partner?
Nursing facilities do get copies.
Okay.
Yes.
So I have several issues and questions, but kind of what Amy was asking about with except I'm on the opposite side of her. Like, I feel like there's just lots of holes even more so now, between the Social Security part and then the DHS part, especially because I have 3 young adults who have recently all turned 18 and 21, and it has been a nightmare and a headache, and only one of them actually has a care coordinator. And I feel like she has preemptively called me and said, I'm going to be getting these papers or I need to turn something in, but I haven't received any other notices from DHS or anything else. And I was kind of almost even threatened to one point last month about this whole set of paperwork that I basically refused to return in because I've already turned it in. And anyways, nothing ever came of it. I never got a notice about it. Apparently, it wasn't required. But I literally got harassed for like 2 weeks about all these papers having to be turned in again.
So I'm going to ask you to email me offline.
Yeah.
And we'll just double check eligibility for your family and make sure everything is
just
okay.
like the trickle down from Social Security. Like if Social Security says disabled, you know, and then people are questioning it on the Medicaid side now. I just don't. It's a lot of.
So if
craziness.
Social Security has a disability determination in place and it hasn't changed, because sometimes Social Security changes their disability determinations.
Yeah.
Maybe not often, but it does happen. Then disability is met.
Yeah.
But again, disability and functional need
Yeah.
are two different things. And yeah.
I mean, but they're already getting that side covered too. But and then even just the is there somewhere where all these abbreviations and acronyms are listed out too? Because I noticed some inconsistencies with some of them, so I wanted to question if they were different things, but I don't know.
You know, I'm not 100% sure if we have acronyms online, but it's a good idea.
Okay.
I'm going to write it down.
Like a list.
Okay. All right.
And then the tracking thing that someone mentioned, I think a checklist would be like super amazing, just because in the past year, not even a year, the multiple times I've been asked to provide copies of my kids' birth certificates to the same people is getting a little bit ridiculous. Like, so the checklist.
From
like,
DHS?
Well, from my care coordinator per coming from DHS.
Because
Yeah.
we have electronic sources.
I know,
It would be
so-
unusual for us at
So
DHS
I
to
just
need the
went
birth certificate.
around my care coordinator and said, I've already talked to DHS. They said they already had that. Y'all don't need it again.
Yeah, and it sounds like maybe you need to
Yeah.
have a conversation with
Okay.
the
Just a bunch
care
of minutes.
coordination and the supervisor.
If I could see like a ongoing, like if I turn something in
Mm-hmm.
for a renewal or some kind of request for paperwork, I've sent all this. Now you tell me you've received it all.
So
You know what I mean?
I will, on Access Arkansas, throughout the entire platform, there are helpful hints like that, things that we might need that you can turn in. But in addition to that, we have improved the information that's available to you as an individual throughout the process. We got a grant that enabled us to do better notification and email, more like a pizza tracker that you see. I mean,
Yeah.
But about you, not just a generic, okay?
That's good.
We have been able to implement that so far for applications, and not just SNAP applications, but Medicaid and T applications. And we are extending that same functionality to renewals and changes in an upcoming release. I don't have that release in my head at this moment. I mean, we can, as a follow-up to this meeting, I can send Jason an email that explains that. But that enhanced process, if you have signed up for alerts, for email or text alerts, then we're going to say, your renewal is due. We're sending you a packet. We've received your renewal. It's at this stage. Or we've now sent you a notice and we need you to do something. It's going to be more interactive. And I will tell you, since we have implemented it on applications, we have seen an increase in our traffic online. This process will even text you. It's got some artificial intelligence included in it. And we are seeing people interact with those messages because there will be a link and you can chat back and forth. So I think it's very promising what we've seen so far, to the point where, we're going to be working with our comms team to help promote that, especially as we make it available for the renewal and change reporting process, just so that people can stay better informed about what's going on and make sure that you know if we need something.
Lakeisha had a question.
I just wanted to say, with submitting of the documents, one of the tools I use is Access Arkansas, because once you upload those documents, they stay in the portal and you can go back and see what's been submitted and it's always there, and it's kind of like a receipt, and it never gets lost. And another thing that I do on there, I check it periodically to see if there's been any messages or correspondence that's been sent to me. And most of the time, the correspondent letters that Medicaid is sending out, they're always on Access Arkansas. So that's a really good tool and a really good resource to utilize, just FYI.
We have worked to make it better than before and definitely make it, well, thank you. And another thing, also to remember is that Social Security is a different agency, and you may be receiving Medicaid or one of our waiver services or even nursing facility, but you also have SSI, right, which comes from Social Security. So it can be frustrating, and because you may be getting requests for paperwork from two different, one federal agency plus a state agency for the Medicaid. So I do know that it can be a difficult process to get through and keep straight what's coming from where and when things are due.
It's like the letters coming from like two different places, and I think that's where the confusion is. Like sometimes it's not coming from Medicaid, it's coming from Social Security, and a lot of people not receiving those letters via the Medicaid platforms because it's coming from Social Security. So determining like where it's actually coming from will be beneficial to like know where to look for that information when it's needed.
So, like, if your past person tells you have something due, should you still receive a notice for it?
So if you have anything due for Medicaid or for DHS, you're going to get a notice and a request for that information.
Okay. So you should start complaining to care coordinator or supervisors then?
Well, I would, like I said, email me offline after this so that we can individually review your case, and then that'll give me a better idea how to best direct you for next steps. Okay.
Miss Mary, this is kind of a piggyback from Catherine and from Brandy. I'm working on the pass side, and now I'm working on the provider side. I'm asking about two separate things, I think, here. There's Medicaid renewals, and then there's the waiver renewal, correct? Mm-hmm. I think what's happening, or what I've seen, is that I've read some PCSPs lately that both dates are on there, but when I worked with my care coordinators, it was hard to get those dates. So we were scrambling. We had to create like a spreadsheet that had all the dates on it, and then we're contacting the members to make sure we're helping them get renewed. And on the provider side, I'm kind of seeing the same thing. I work for a waiver provider. Is there, based on what you asked, Brandy, you said there was a list that went from Medicaid renewals out to like the nursing home. Is there a list that goes with the waiver renewals and Medicaid renewals to the passes?
No, but I was going to say, Elizabeth's coming up. There are plans to add additional information to the 834 forms for passing.
And additionally, I'll just use this. Sorry. We are also working on putting the redetermination dates on the eligibility strip. So when a provider goes in and checks, it's informational only. You can't rely on it for billing. You still have to check your eligibility every day to bill, just like always, but it will be there to help with like personal care providers and other providers knowing when those dates are coming up.
All right, all good questions. I previewed that Mary has a sneak peek to some of we have one online. Yeah, you can go ahead, Crystal. What is it?
Angelica asked, is there any known issues with the emailing system? She started getting emails from DHS, then it stopped. She had someone from DHS in Little Rock call her, walk through the process to update her Access in Arkansas account, and the settings were all set to receive correspondence. But it only worked for a while, then stopped receiving the emails.
Has there been any known interruption in email?
No, there's not been any known interruption in emails, but if we get a bounce back for some reason on that email address, then we revert back to paper until we can reestablish a good verified email address. So that is just an example of what could interrupt the process, because, we are required to communicate by mail. We are allowed to communicate by email if our client chooses to receive their information that way. But if that email bounces back for whatever reason, and sometimes I think they bounce back just because of in-transit server communication issues, not necessarily because the email is no longer valid. then we have to revert back to paper until we can re-verify. But we do send a notice that says, we're reverting back to paper, we need an email address, and we can start the process again.
Okay. Good questions.
Yep.
And I think, too, what could be happening, because I actually got a letter from DHS saying how we will contact you when I had elected for that. And it was reminding me that if you don't go in and verify your email address, because just because you put your email address in doesn't mean that you're going to get the correspondence. So that may be what's happening with a lot of people, too, is they're not going back to that step to verify their email. And then you very politely send out a letter telling them that they need to verify their email. And so that too could be what's happening there.
All right, Mary?
Okay. Notice changes. We've been talking about notices for a long time, and we have done some work on this. And part of the reason my phone was dinging earlier is because I asked somebody to remind me when some of this was going into the system. So, notice changes preview. We have started on the request for information, and I am sorry this is small. I wish I could make it bigger. But on the, because if you're facing it, it's on the left. This is a sample of what the notice looks like now. This is a preview of what it will look like. We've changed the whole template. We have, so there's more color in it. Now, I'm not going to guarantee that these are going to go in color in the paper mail, in the U.S. mail, but they will be in color online, and they will at least be grayscale in the mail. We're going to check on prices and go from there. But, we're using color like action, the red. What do you need to do? And then it tells you right there what you need to do. You must send information by the due date or your case will be closed. And then we have organized the table differently. So we're telling you in this case, this is a notice for SNAP and for healthcare. We have the due dates. They're just, you can see it all more in one place, I think. And so we're hoping that this is very helpful. And do you see that QR code right there? Yes. All right. That is going in mid-November, and it will be an additional way for clients to return information to us. Even if you do not have an Access Arkansas account, you will be able to scan the QR code and upload documents directly to your case. Just as another, plus all the ways you can normally do it. You can mail it to us in the post mail. You can email it to us. You can upload it online through your Access Arkansas account, or you can scan the QR code and upload it that way. So that is happening in mid-November. This full template change, we're holding it back. So you'll see the QR code on the old style of notice before you see this new style of notice, because we wanted to actually update the words a lot more too, and put out the new format with better words at the same time, okay? But the QR code is going on there mid-November. And again, this is on the left, the old request for information, and on the right, how you can send the needed information. And again, the QR code, if you want to, even if you don't have an Access Arkansas account, you can scan it and upload it. What you need to, if you're having trouble getting the information, what you can do, how you can contact your caseworker, and they will try to help you. And some additional information about how long it will take to process your application. So that is a sneak peek of what we're planning for on the request for information. And this is a notice of action. And again, on the left side, how you see it today and how it will look in the future. I think this one has probably undergone the most change. And in the old way, you had the program's broken up, you know, healthcare, and then you would have approvals and denials separately, and then you would have SNAP and approvals and denials separately. And we found it very confusing to people to tell them, you've been approved for our kids B, and then you've been denied or closed for our kids A. It was confusing to people. And really what we meant is your category's changing. So one of the things we have done is the first page of this notice of action is more of a high-level summary of everything that you need to know, so that if you stop reading after page 1, hopefully you've gotten the gist of what's going on. And so we're telling you everything about health care in one place. John Doe, I'm going to flip to that page in my paper presentation so I can see it better. So we're telling John Doe that he's been approved for nursing facility care with the effective date, that he's been approved for qualified Medicare beneficiaries, because we often approve those both at the same time, and that is to help prevent interruption in the Medicare buy-in. If for some reason the nursing facility case closes, if he goes back home, his Medicare buy-in will stay in place and his QMB will stay open. That's why we do that, if you ever wondered. But we also are saying our home's going to be closed, but he doesn't need our home because he's approved for nursing facility. So, and then there's a Jacob also in the home that has been denied for Medicaid. And the reasons for his denial are in the following sections. And we're telling them about SNAP, that the household, there's been no changes in the SNAP benefit, and the SNAP benefit will continue, and that the person not included in the household or denied SNAP was Jacob. And the same thing for T. So we tried to make the first page an overall summary of what's happening with everybody, but in one place. And then the next page breaks it out in more detail by the categories, by health care. And then if there's anything that you need to do, you're going to see that same red action. What do you need to do? You know, our color scheme is going to be the same across our notice template. So when you see red, that means there's something that you need to do. And then there will be instructions. And there's instructions are listed by individual. And then the green is just other important information. And this notice is a mock-up of someone who's been approved for a nursing facility. And what we tried to do is make it much more clear what needs to be paid to the facility for the person by month. And then we do the same thing for SNAP. We go into more detail. And an important information would always be in green. And same thing, we're talking about T and how you can submit the needed information and what to do if you disagree with the decision, how to file an appeal. So those are our RFI and notice of action changes. And we also are streamlining the summer EBT application using the same color scheme and explaining who's been approved and any action that needs to happen. So, again, we're working on the verbiage because we didn't want to just make a nice template that's easier to follow and keep confusing language. So we are holding off on implementing this template. I think we are scheduled for June. So we are giving ourselves more time to get the words better. But the QR code, you'll start to see that middle of next month. Anybody have any questions about this?
Or suggestions.
Or suggestions.
Since this isn't going to be implemented until June, we have
There is
the
time for
opportunity to,
suggestions.
I don't have any questions, but I just wanted to tell you thank you so much for listening to our voice about these notices, because it's been kind of a long journey. I know even longer for people that been on. I've only been on a year, but I think this shows such the value of this council and our connection and partnership with DHS, because this is so much better, and also will be better. I'm always going to be an advocate for the passes and for the members. I think if a care coordinator picks this up, it's going to tell them so much more than trying to go and dig and find. But thank you for the QR code, because we had talked about, well, what if you don't know, you don't have Access to Arkansas, or you don't want to do it, and now you can just click on it and submit your information, the timeline, and then what everything's going on with everybody in the household. I know for me as a single mom with 4 or 5 kids that have different benefits, it just tells me so much more than all the different letters that I'm getting. So I just want to tell you thank you.
Well, you're welcome. And thank you all for the input and suggestions. Definitely.
When using the QR code, will you receive some sort of confirmation that the documentation has been submitted? And will that documentation be available in your Access Arkansas? Like, what type of confirmation will we receive when using the QR code?
You know what? That is a good question. I will say, yes, it'll be in your Access Arkansas account. So if you log in, you should see that document. But I do not know right offhand if there's a automatic reply, success, we received your document. But that's a good question, and I'll find out, and I'll follow up with Jason.
And then I was just going to add, I do like all the colors. That's really amazing. And I've been reading those papers for like 20 years. So it was like a lot of words. I think having like a side-by-side, because I don't think a lot of people even realized what you were saying in those sentences forever as you turn the page. And again, it's just another black and white bunch of sentences to point out, like, here's what the new information we're showing you. Because I feel like there's probably stuff on there that wasn't on the old notice, So, and here's where this information is now, like a side-by-side, just because I feel like if I didn't have to study those papers for so long, in my experience, that I probably would have just started throwing them away at some point, because it's just a bunch of...
And the notices can be long, and the notices are still going to be long, but we're trying to present the information differently so that you get the most important things, right up front, and then you can read more details in the other following pages. But that summary on that notice of action, we're hoping is much more helpful to actually just, what are you trying to tell me? And then I can go get more details on the following pages.
Crystal has a comment or a question from one of our Zoom participants.
Angelica asked what the landing page, when you scan the QR code, what that is going to look like.
And I do not know yet, but I will find out. Landing page, I will see if I can get you guys a summary of what what is it going to say when you scan the QR code. And
because did you mention the QR code is for people who maybe aren't on Access Arkansas? Like it's a
you don't have to be on
You don't
Access
have to be,
Arkansas,
right?
but you can be.
Right.
I mean, so Access Arkansas is not going away, and
Right.
you can still have an account and thoroughly interact with it as much as you want. But if you don't have an account and you want a quick way to get us information without having to mail it, drop it off at the office, or email it, then you can scan and upload it through this QR code.
And if you are on Access Arkansas, you'll be doing both at the same time. It'll go to that account. Cool.
Yes.
All right. I really liked when you said the red, because I can look at something, and if it's red, I'm like, I better read that. Okay. Any other questions or comments for Mary before we move on to the next item on our agenda? All right. Thank you, Mary.
Thank you, everyone.
Okay, so I was told that Paula presented on this topic earlier, or this week or last week, and went an hour, but she has condensed this presentation for us. But Director of the Office of Substance Abuse and Mental Health, Paula Stone, is here. She's going to be handling it solo. Melissa's not here. She's going to talk about the right time intervention model that's being used to help with treating children with behavioral challenges. So let's welcome Paula.
Hey everyone, so this is just an update on everything we've been doing in children's mental health and our path forward. So this you guys already know, I do believe, what our role is We have to tell people this all the time, though, that DHS's role, because people get confused, right? They get confused that it's more about child welfare and that we're the group that takes children into custody and into foster care and do adoption, but that is absolutely part of what we do. But I think they also don't understand that the role Medicaid plays in behavioral health services. I found myself telling people over and over again is that Medicaid is the payer for about 80% of all the behavioral health services that are provided in Arkansas. And so just thinking about how we do that in the right way to make sure we get our biggest impact is one of the things that we've been really thinking about and looking at how we do that with very, very young children as well as those that are having some pretty significant issues. So we did a big study in March of 2023, and because at DHS we're not just Medicaid, we have the Division of Intellectual and Developmental Disabilities, which everyone knows about here. We have the Office of Substance Abuse and Mental Health. We have the Division of Youth Services, which is our juvenile justice arm. So not every child or youth that's involved in juvenile justice is part of the DYS. Some of them go into juvenile detention centers in their own counties, but we have that group. We also have, again, child welfare. So really looking, we have a pretty big lens into what's going on with children. And children that are in juvenile justice and in child welfare have a higher incidence of mental health conditions than other children in the general population. So we came back and looked at our challenges in Arkansas as DHS, and we looked at the things around entry points. Are we having people enter into how many different doorways, and are they entering the system in a way that we can help them? Partnerships, so all of the partnerships that we have that I just mentioned across our own agency and then across other agencies like the Department of Health, the Department of Education, and then programs to make sure that we have all of those programs in place. And it's not just Medicaid services, it's also some supports that we can provide in addition to Medicaid treatment services. So here was the 2023 report. We need to expand community-based services to prevent institutionalization and have step down for children who are coming out of more acute or residential settings. We need to create a responsive crisis system with mobile crisis as well as in-home support instead of children just going to emergency rooms or to psychiatric hospitals. We want to improve that care coordination and discharge planning to strengthen that between the Division of Medical Services, so DMS, DCFS, and our PASS. We want to enhance screening and placement because we know that to reduce those disruptive transitions in a child's life. We want to maximize both our Medicaid and our Title IV-E, which is our child welfare funding, to ensure that we have some continuity. Sometimes child welfare or juvenile justice is paying for something with their money, Medicaid's paying for things, and OSAM's paying for things. So just really making sure that we have those efficiencies and then support the seamless transitions into adulthood for youth with complex needs. I think I shared this with you guys probably, it's been a year and a half ago. And so one of the things that happened was internally, we were working with our partners in child welfare and talking about how we're missing kids and how they come into the system, how we're missing the families, and what we can do. So we got together and we looked at all the data we had, which was Medicaid claims data and child welfare data when somebody comes into custody and goes into foster care. And we did a map. So we used the same vendor that we use to process map a process that we do for a program or a policy or anything that we're doing, and we process mapped a child's journey. This was a kind of a stunning example of where we missed them. And so unfortunately, this child, we still were treating them at 21. We still knew who they were. We were staffing the case, and we were making sure that they were getting the services at 21. And we said, let's see what happened to this child. So for this child, not on anybody's radar, until they went to school at age 5. Nobody's radar, not child welfare's, not developmental disabilities, not a primary care physician, no one's radar. And then when they went into the system, or when they went into school, they got OTPT and speech. So that was our first notice that something was going on there. So they had some developmental delays. And then the school filed a FINS petition. That's a Family in Needs of Service petition, because that child wasn't attending school regularly. And so they did that. And when they did that, they identified some issues in that home, and they took that child into custody. And that child went to their very first foster home. And I can imagine what a child is who's just gone into school, has never really been outside of their home, obviously was not getting services prior to that, and then they went into foster care. And that foster parent struggled with that child's behavior and took them to their very first crisis setting, which was a psychiatric hospital, and that child was admitted to a psychiatric hospital at age 6. And if you see that journey of that child spent more time from age 6 in institutions than they spent in a foster home. So they would go to a foster home, and then behaviors would occur, and the foster home would seek behavioral health treatment. They would go into a residential setting, a psychiatric residential setting, or acute hospital, and then they would go yet to the next foster home. So the very brief times of foster home, at some point during this journey, the mother's rights were terminated. And so that child was fully, the goal there was to have a family to adopt him, and that did not happen. And I think he did his first, I'm having a hard time saying this, but I think this is the one who went into his first juvenile detention center, juvenile justice setting at age 12 for a charge. So then after one institution after another from age 6 to 12, did the first entry into juvenile justice, eventually went to our Arkansas State Hospital. So we have a very small unit for adolescents that we run at the Arkansas State Hospital that's generally reserved for children and youth who have, well, it's actually youth over 12 and 12 or older. And we saw that we missed the diagnosis. They diagnosed him with fetal alcohol syndrome disorder. So I got a good diagnosis, but not until age 12. And then you can see the rounding back from age 12 until age 18 of moving around from facility to facility, treatment facility to other treatment facility. So we took this back and said, you know, what can we do different? This is no way to move a child through the system. We are obviously not providing the right supports. And what can we do to make sure, and this was not the only path we did. We did this same experience for other children, youth, 21, 22-year-olds that were struggling to make sure that they had the appropriate services. So this weighed heavy on all of us at DHS and said, what can we do? So I just went over that journey map piece of this. I think I called out everything on here. So it's just that fragmented past. It's reactive. It's disconnected. It's too late. We reached out too late. So where were our early screening? Where were our connection places? And where were our right time interventions? Obviously, we did not intervene in the right time and with the right intervention. So we looked at all of those missed opportunities that were supporting standard development and supporting a mom that maybe could have received treatment and been able to have that family stay intact with the right services just wrapped around them. So we really want to make sure that we're looking at entry points and right time interventions. That's where we said, you know, that's what we want to focus on. We can develop all kinds of policies and all kinds of services and all kinds of programs, but if we're not making the programs or the policies, putting those into place that target the right time interventions, then we're not moving our system forward, and we're not really supporting those children and those families. So here is the list of things that we have said, okay, Some of these are new, some of them are in progress, some of these are policies, some of these are programs, and some of these are pilots. So just going to go through each of those on subsequent slides, but what we've got, so we targeted very young children, so we've got a list of services for very young children. For children and youth, and then transition age youth that are transitioning to adulthood. So these are all the services that we either have in place or we're looking to pilot to bring them in place. So for our very young children, we have a program called Healthy Steps, and this is a program in primary care. It's for 0 to 3. It was developed for 0 to 3, and it is supporting families and young children when they come to their pediatrician. It is a grant that the pediatricians got together and wrote, and it is funded through a grant. We don't administer the grant, but we have a great partnership with our pediatric physicians and their organization. And so we've got that going on out there in they have a social worker that's in the clinic, in the practice. They do screenings, they do all kinds of things that are really supporting the families. We have infant mental health, and infant mental health we've had in our program, in our system, our Medicaid system, I'm trying to think of when we got that approved. We got that approved probably back in 2017. And so what was going on before 2017 was that our behavioral health providers, our Medicaid, mental health providers were identifying children as young as age 2 with a mental health diagnosis and providing treatment for that mental health diagnosis, but that wasn't really the right treatment. I think they were doing what they could, but we really wanted to make sure that the treatment was correct for those infants and mothers. And the treatment that's right for that is there is a diagnostic manual that's specifically for age 0 to 5, where you do not have to diagnose a very young child with a mental health condition. You can diagnose the parent-child dyad with that issue, or you can diagnose something called failure to thrive, or you can diagnose all kinds of things that are not mental health conditions. And so we put that into place, and we really didn't get much uptake in that service being provided. So I think what we've kind of realized, back to the right time intervention and the entry point, is moms with a 2-year-old aren't going to a mental health provider, to a community mental health center, and saying, hey, I'm having some difficulty. We're not finding them there. So we have found a small grant that we did in conjunction, OSAM did in conjunction with UAMS and Excel by 8 Foundation, where we have got a person coming in, and we're going to target 2 places, and those would be our entry points for infant mental health. One is pediatricians' offices, so we could provide that service and identify people who needed that service. And 2, because it's a Medicaid billable service, just because we make the policy doesn't mean people go out and bill it. And 2 would be our specialized women's services program. So we have a pot of money at OSAM that's specifically, it's block grant dollars specifically for specialized women's services programs. And specialized women's services programs are residential programs to treat women with substance use disorders, and their child can come and be there with them. So they can live there together. The mom can receive intensive treatment. Most of those mothers, many of those mothers are our home beneficiaries, and our home with the qualified health plans can pay for substance abuse treatment in residential settings. And then really looking at how do we provide the services to those young children that are there with their moms, and this is one of the ways. So we're going to be training those providers in infant mental health, and they're all enrolled Medicaid providers, and they can bill infant mental health services while the mom is there. We have Maternal Life 360 homes. I know Elizabeth's presented on Maternal Life 360 homes to this group. That is where we have an 1115 demonstration waiver, and those women can be identified when they're pregnant as high-risk pregnancies, and then have home visiting. So really targeting every place we can here. A lot of that's done through the hospital. So again, identification is key here, and hopefully we can identify those mothers and children in need. And then we also allow pediatricians now to, or family care doctors, to bill Medicaid under the child's Medicaid ID for maternal health and depression screenings. So we've got all those screenings for the child, but we also know that sometimes mothers don't go and follow up with their own care, but they will follow up with their child's care. And so making sure that that's a place where we intervene with them. Our other needed services that we're building out are adolescent substance abuse residential, which we've not had in the state. So that is going to be a Medicaid paid service. We have money that went out to Unity Health, which is a hospital in Searcy, and they got money for construction, a construction grant. So they're constructing a separate unit, and then we're working on the policy piece of that. I think that unit is going to be, as soon as it opens, hopefully in the late spring of 26. I think it'll be completely full. I think it's going to have 28 beds. Our goal there is to have those youth treated. It's a short-term residential, probably be about 45 to 60 days. Our challenge is going to be getting the services back in the community because those children are going to come from all over Arkansas. And so if they can't get follow-up care in the community, if we can't get those services in place, I think we're going to have some challenges there, but we want to work on those challenges. Community reintegration for children. So we didn't have that back then during the that young man's journey map. So community reintegration we developed that's probably back in 2017 as well. It is a step down. So instead of a child going into an acute hospital or a psychiatric residential, when you go into psychiatric residential, you stay for about 6 months and then you come right back out, right? And you come back to your home, back to your community, and you've had all this intensive treatment, and then you're just back. So this is a step-down service, which we would hope that most children get that step-down service. It is a group setting. It is a 16-bed or less unit. It's unlocked, and those youth who have those specific challenges go to school in the community, get all kinds of services and 24/7 supervision, and then they work on that next step down for them. We did have some construction grants that we sent out for that. We've only had we had one provider for years and years and years, only one, and it was like a 12-bed unit in Fort Smith. So we've got 2 construction grants going on. So we have 2 more opening. And then we're doing a project with Child Welfare with DCFS, where they're going to be paying some extra payment to some of the providers if they open a community reintegration and take the children in foster care with the highest needs. And so I think that's out on the streets right now for an extra $100 a day for them. And that seems to be creating a lot of interest. So I think we'll have another maybe 4 that come online with that. So we're really excited. We've talked a little bit about the pilots that we're doing, just that assessment, right? That assessment piece. And again, back to our entry points with our assessment pilots and really looking how that's going to turn out. So we did 3 different assessment pilots, more in a crisis situation, making sure that we go in there and make sure the child has the right diagnosis, make sure that the family is supported. This, again, is that goal of keeping someone from calling an ambulance or calling the police when a child has an issue, particularly those that have come into custody and they have that time where they're overwhelmed with the behaviors that are being displayed. So we've got those 2 pilots. It looks like where we're looking towards is merging those a bit into one kind of program. But we've got some time with our pilots. Family-centered treatment. We're really excited about family-centered treatment. So this is also, I think our goal is that if you're coming out of a psychiatric residential treatment facility, you're going to get one of 2 programs. You're either going to step down to community reintegration or you're going to get family-centered treatment. And family-centered treatment is a very intensive service. It's 6 months. We've been piloting it. Medicaid's going to pick up the payment for it in January. And it is going into the family's homes and giving them wrapped around services and really treating the family as the client, although it's going to be billed under that child's Medicaid ID. So we've had 7 providers out there doing this. They're going to continue with us. We have seen great results with family-centered treatment. You can see some of those there, but 92% of the families engaged in the service, they're not in the clinic. They are in the home. So you do not have to go to the clinic for these services. And they provide 24/7 crisis with a person who knows your family. So families don't have to call an ambulance. They don't have to call the police when something's going on. They're going to call their team, and the team is going to, in real time, coach them through and then follow up with them very quickly, if not go out. And then we are also family-centered treatment has a recovery arm to it, which focuses on women and men, so parents with substance use disorders. And so that's another thing we're piloting is saying, okay, so we want family-centered treatment, and then we can identify those women. So back to our specialized women's services, we can identify and have infant mental health going on for young children while they're in care or in treatment in those residential treatment facilities. And then we're going to make sure that somebody follows those families back out into the community and provides family-centered treatment recovery. We're funding that right now, that pilot through one of our grants. It's a substance abuse grant called State Opioid Response Grant. So we've got all of those things going on, working again here with our child welfare partners, because a lot of women, probably most of the women that go into specialized women's services residential programs have been identified by the courts and are involved with child welfare. So again, entry point, right service, trying to catch them while we can is like, don't let a chance, our goal here is not to let a chance get past us. Here's another, am I getting close?
Oh, I thought you were wrapping.
Sorry. So this is another one of our screening programs. So just really looking at those two screening programs for young children. We are also doing a couple things. We're doing some psychotropic med monitoring because that's the other thing that happens when children go into psychiatric residential treatment. So we've done a lot of policies on psychiatric residential treatment facilities in the last 6 months, really. And so those children are put on a lot of medications. And then when they come out, then some of the outpatient physicians are really not comfortable following them on those medications. I learned most of the medications for children are being used off-label because they've not really been tested. Psychotropic medications have not been tested. And a lot of them we're really concerned about is that sedating effect that's going on. So they're so sedated when they're in psychiatric residential that's what's kind of controlling their behaviors. And then when they come out, you can't function well. And so I think one of our questions was also, are you really getting good treatment? If you're so sedated while you're in a facility, are you really getting good treatment? So we're doing a big piece of work on monitoring the prescribing of those medications and how they're being used. And we're partnering with our PASS on that. And then we're developing a new service called Therapeutic Communities Level 3. We have Therapeutic Communities 1 and 2 for adults with mental health conditions. They're facility-based. Level 3 is really going to be around provider-owned housing, taking a page out of the IDD book and saying this is how they've been treating for a long time. This focus is on all of the services being provided in a community setting. So they'll be in their apartment, but the goal is supported housing, supported employment, really helping adults with a serious mental illness, particularly our transition age adults, learn to live in a community and be successful in a community and have that support. I think the other thing we're doing is our pilots on back to Healthy Steps, looking at that patient-centered medical home that we already have in the Medicaid system and seeing how we can target that for children and mothers of saying, okay, this is our place to intervene. Can be our right time intervention. How do we do that? So just looking at how do we weave all these things together as a Medicaid payer and get those going. And then we've got a pilot going in 7 areas of the state with a statewide crisis system. We know that the success to a crisis system is someone to call. So that's a single number, not just 911, someone to call. So we're setting up a call line, a 10-digit call line, and piloting that. We've got vendors who do this in other states that are going to come in and answer that call line. In Arizona, we found that Of the people who called the call line, 70% they could stabilize on the phone without having to dispatch anybody. So that's someone to call, someone to respond. So of the 30% that could not be stabilized on the phone, having a true mobile crisis team go out and if they need to go out with law enforcement or with an ambulance service, having that co-responder that has that behavioral health experience to be able to stabilize that. Again, in Arizona, they've been doing it for a long time. They stabilize 70% of the people when they go out, they stabilize them. And then the other 30% that are left out of that 70 of that population, and then they can also transport to a crisis receiving center. So that's the last one, someplace to go if you can't be stabilized in your community. So, and then just really looking at our well child visits. So this is our right time intervention. This is what we're envisioning. So we're trying to weave all of this together with all of our different funding sources, Medicaid being the base of this funding, and saying, okay, how do we make sure we have this framework? How do we work with our partners? How do we make sure that we're identifying families early and responding early? And then if we haven't been able to respond early, so we've got a lot of, 15 to 18-year-olds currently in the system, how do we put in the right services so they're not just rounding through psychiatric crisis to residential, back to psychiatric crisis? So just really doing that. And wrapping that family in all the supports we can. So making sure that that family is part of that work, is that we're not just treating the child in a clinic in a vacuum. We are doing that. So, and then not just symptoms. So hopefully we can keep children from being diagnosed, right? Is to look at what's going on in their lives other than just saying this is a symptom of a mental health condition, because it's not always a symptom of a mental health condition, even though it may look that way. And really emphasizing that social emotional development, right? That's what we want to do in the young children, is saying, okay, let's get you to school ready and prepared and have the appropriate social emotional development. Now, Jason.
All right. A couple of questions before we take a short break or comments.
You know, I always have questions, Paula. Sorry. I'm really excited about this because I remember when I worked in Power, we were doing all these groups, and especially we have an item on our agenda today about autism assessments, and it sounds like you're trying to solution that with this CSAC. So I have two questions about that and healthy steps. In that assessment, are we also going to be looking at, I think you are because it was on the slide, the complex care, to get rid of some of those diagnoses, but also to take a look at the speech issues, the early developmental issues that often lead into referrals over to the DD-IDD waiver. So is that part of the assessment, physical and behavioral and DD-IDD?
Yes, absolutely. So yeah, all the screenings occurring because Medicaid will pay for all the screenings in the pediatricians or the primary care office. And so really making sure, and this is you get your screening, but are you assisted with that follow-up? And then after you get your follow-up and you get your diagnosis, are you assisted in getting to the right place? And I think that's, what we're making sure that, we try not to call something else care coordination. That's something, but really thinking about how can we embed somebody to help them navigate the system.
That was my last question. You kind of already covered what's the process map look like from there. As a provider, on the provider side now, will we be getting kind of some of those referrals? Where I work at Myers-Davis, we do a lot of different services beyond the waiver services. So I'm thinking about like your 15 to 18-year-olds that are reintegrating, foster care, they're coming in. A lot of that's trauma, but everybody needs independent living skills. So are there referrals that go out from these assessments and from all these programs to get them additional things that they need?
So for the deep end programs that we talked about that Medicaid covers, so family-centered treatment, community reintegration, therapeutic community, those are all only for past members. So they've got their care coordination piece of that. But then for the entire Medicaid population, it is that guidance of guiding them if they need a deeper in service. So I think our goal is for Medicaid population, making sure that anything that's available to a Medicaid beneficiary, so OTPT speech, and counseling services or any of these other services that the primary care physician or whoever identifies is able to connect them. And we've got that family piece of that in there as well to see if anything else needs to happen. And then for deep end services, making sure that they get that referral to the PASS.
And this is my last comment, Jason. I'll give the microphone back to you. But is that a solution to some of this long wait time for autism diagnosis? I'm on the board at Arkansas Autism Foundation, and one of the things I'm hearing when we're going out to all the parents that have kids with autism is the wait time, and they can't get any services. Is the CAC going to hopefully resolve some of that? Because we only have what I'm hearing, and I don't know, is because I did an independent assessment for my child, is that what's the place at UAM, the Dentist Developmental is the only assessment center. So I met with a couple of parents that they've been waiting 3 years to get an autism assessment to get any services for their children. So they've had to quit their jobs, take care of their kids at home. Is that what the CAC will be doing?
Think one of the places that we hope, let's see if I can back up. One of the places that we want to make sure that we're doing full-on diagnosis is when you're in a psychiatric hospital, is paying, we're going to have to do a manual change on that one, paying for that full spectrum look at them. So we're in a psychiatric hospital. Now, we don't want everybody to go to a psychiatric hospital for that. And then I think we're having some other conversations. I had a really interesting conversation, so that's not on this slide because we're just in the beginning stages, is that UAMS has a program that they were doing, and it was called it's called a trauma assessment, but it's much more than a trauma assessment because it's done by psychologists that are trained in trauma. And they've expanded it to psychologists around the state. And it's only been for child welfare. They lost some funding. They had victims assistance funding that was coming in. They lost some funding. And so that was one of the places where I was thinking, well, if you're already out there doing this and Medicaid's paying for it in some degree, and you just need some other funding to kind of glue it together, could we not use this out in communities instead of just dentist developmental? So we started talking to them about having a speech therapist. So Tony's working with them on thinking about how do we build this out. So one of the things we want to build it out as we were looking as more of a daily rate service. I don't know. We could talk about that, but yeah.
I'm familiar with that. They have it set up for the priority of the foster kids that they do that assessment.
Yes, yeah. So yeah, I'm sure you may have some ideas on how could we maybe broaden that and use that to address some of our access issues for that kind of testing.
Sorry, I have a lot of comments and questions. The first thing I want to say is this is incredibly frustrating, and I really appreciate your work on this. This is incredible. I mean, I didn't even know that with that map that you put up, I didn't know that's something that you hear about, but you hope that that's not the reality, right? So I have a few questions, and they're all kind of all over the place. You talked about pots of money and grants. How much of that money is actually being used? Is there money left over at the end of the year that is not being utilized, or is all of that being used?
We are using all of it.
And
We've been very, very careful about how we use our block grant dollars. And I think, one of the things that we look at is, one of the things that's bothered me for years is that everybody goes out and does their own program, right? Mm-hmm. Is how do you weave that together and create efficiencies? So how are we not you're paying for this and I'm paying for this, and the poor providers out there, right? And they are and I think about the specialized women's services providers. I don't know how they do it because they are getting money from, 5 different grants and Medicaid and commercial insurance. And so I think one of the things we're looking at, and I had a meeting this last Friday of how do we at our level at DHS braid that funding together or blend that funding in a way so we're putting it out as a package. So I think this is the first time that we've done that in this partnership with DCFS where they're saying, okay, Medicaid's going to pay for this, we're going to pay for this, and it's enough, and then the provider knows I'm going to get this daily rate service. So, but we're using every penny of it. We don't turn any back in. And so we've got 2 pots of funding on the substance abuse side. We've got a block grant, and we've got state opioid response dollars. So.
Yeah, because you've got all of these, the pots, and then you've got the providers, and how this information changes every year at least, I would think, probably more often than that. And how do the providers actually get this information to do anything with it? Yeah. That's the really frustrating part.
It is. It's a challenge. And, we've got one grant called Behavioral Health Integration Grant. It's with UAMS. It's a state Substance Abuse and Mental Health Services Administration grant. And we're trying to do that and push that out there for primary care. So it's really about, I think, you guys and us. I was on a call this morning and they were talking about a program they're doing. I was like, well, I knew nothing about this. And it seems like what we're doing. So I had to send them our thing and say, can you convene us all? Because, this money's coming at people from all different directions.
So you talked about working with Excel by 8 and the Department of Education. Do you work with specific school districts, or does it come from Department of Education to you?
So the way that works with school services, and it's not very standardized out there, but our Medicaid providers work with their local schools. And so we try to do some programs at the state level or at with our pilots, then we do that at more of a community level and try to get some standardization going out there. Because I think that is another one of our challenges is the way Medicaid pays for things. Each community may just use their services in very different ways. But we do try to work with the Department of Education to have some policies and procedures in place.
I'm a little bit, it hits a little close to home for me, not because of behavioral issues, but I have a child who is in 4th grade who we just recently discovered is dyslexic. And I am confused on how we got to 4th grade without realizing this. So when you talk about this, I think, how do you get to 12 years old without anybody picking up on it? And my kid is in Little Rock, so we were part of the Little Rock School District. And, that place is stretched as thin as it can be stretched. And I'm sure they're not the only district. So I asked that question because it's got to be individualized for the different districts. And then my other question, how many babies in Arkansas are born that never go to a pediatrician? Do all babies do all mothers take their kids to the pediatrician? You're supposed to, but
yeah, and I think that is a good one. I don't know the answer to that, but
how do you find those people?
Yeah, and I think that's it. That the group I was talking about that I was listening to this morning, that's exactly what they're doing, and they're a group out of Jonesboro, and they're hitting the Delta, and it's through that Doctor of Osteopathy school that's in Jonesboro. And it's just 3 of them, and they've got some funding from Minority Health Commission and some other places. They're just kind of patching it together, and it sounds like they're doing great work in getting moms to trust and be part of the system, and then they're able to give things out. If they keep appointments and they do this and participate, then they get gift cards for like Pack and Play or all kinds of things for their babies. So really thinking about I was like, well, we don't have to invent that. We just jump on board because that's going really well. So I think that's the piece of how do we jump on board. So I think it would be really great for you guys, as you know about programs that are going on out there, of bringing that back to us and say, okay, how does Medicaid intersect with this? Because I don't think when programs are out there really looking at that, even schools, I don't think they understand that Medicaid's the payer, right? And I think that's where your voices really come in. It's like, we know, right, that Medicaid is the payer, is going to be the bottom line payer for most of this. If 80% of the kids that are getting behavioral health service, and what's our percentage of Arkansas children that are Medicaid eligible? It's up there, right? I mean, it's 50%. So generally, Medicaid is going to be paying for a lot of, if not the service, it also kind of, our policy really creates that infrastructure because we're the largest payer. So I think anything you guys can do to help us hey, y'all need to talk to Medicaid about this because, we're not out there in the community every day. And I think people miss the fact that we could work with them.
I think Heather heard like I did in your example of the chart that child wasn't on anyone's radar, including a primary care physician,
That's right.
until they went to school. And that's what I heard too. Was there anybody online, Crystal, that had any comments or questions?
Yes, Corey asked, are there plans to expand the available placements for treatment? They state, for example, my son has profound ASD. He's only at 15 developed any behaviors that were concerning. We took him to Children's ER twice, and there was nowhere that would or could take him. UAMS has a good program, but it does not cover children his age. However, he is too young for the adult places. He is nonverbal, which excluded him from others. I know my son is not the only one in the state, and it is on the rise. I'm hoping there is being some talk on expanding options for families like mine.
Yeah, it has been, I think one of the things we'll talk about doing is, again, back to the psychiatric hospital diagnostic service. You know, there was a psychiatric hospital in Northwest Arkansas that opened an autism unit, and it lasted 3 months? 3 months. Because they couldn't keep their beds filled. They didn't get referrals. So I think it's, and I don't know why that happened. Yeah, so I'm looking at Amy. I'm sorry, we're chatting about it. But, you know, I think that looking towards, you know, where do we embed those services and can they keep their beds filled is really what's making sure that those services exist. So I think, again, with your voices here is how do we work together and you be our eyes and ears out there in the community, and we can bring things like that to you guys of, okay, well, there's a psych hospital here and their beds aren't filled, and yeah.
All right, Paula, thank you so much. We are going to take a 5-minute break. Before we do, I want to welcome Jennifer Prunty to the council. Jennifer, this is her first meeting. She's going to get her picture taken over here with Stephen during the break, and we will reconvene in 5 minutes to talk about MAC proposals. So for those of you watching online who maybe don't know, we expect our council members to serve 2-year terms. Doesn't always happen. Things come up. Some people have good intentions going in, but they just find their schedule's too busy and they can't commit, and so they fall off. So we have 5 people today who have made the 2 years, and they will be invited to join our alumni council, our alumni group. And we wanted to just pause briefly for those 5 members. We'll recognize them on the screen, have some photos of them participating in past council meetings, and give them an opportunity to just say a few words about their service, about the time that they spent on the council. So who is up first on our slideshow? Why they serve. We call it Why I Serve. Casey's not here today, unfortunately. This is the bio that appears online. You could go online to our website at DHS under the Medicaid Client Voice Council and read about her. So we thank her for her 2 years of service. Who is next? Heather is next. So Heather, thank you for your service. And if you have anything you'd like to share about your 2 years.
With all of the roadblocks and challenges, and just thank y'all for showing back up every day.
Thank you, Heather. All right. Up next to be recognized at their final meeting is Rebecca. She is out in the hall. She's wrapping up a phone call. Here she comes. Just in time. So Rebecca, we're just having an opportunity to thank you for your 2 years of service. We've got you up on the screen, and if there's anything you'd like to say about your 2 years, now's the chance.
Thank you. I just want to say that I'm very grateful for the opportunity to be on here. I feel like I've served 4 years because I served 2 with Bradley. I feel like I came in feeling there was a disconnect between the people in DHS. I feel like I'm leaving with a different outlook. I feel like I see them in a different light than when I came in, that they really do care. We just weren't on the same page. So I feel like I've benefited a lot from serving.
Thank you. We've appreciated your service and Bradley's service. Bradley's in town. For those of you who never met, Bradley is Rebecca's son. He was one of our original council members. All right, and Brandy, our chairperson.
Thank you. Just want to express my sincere gratitude for being on the board and serving as chair has really been a wealth of information and a great educational experience for me. And I think that that's something I'm going to be able to take back to help with a lot of my clients in the future. It's been great getting to know everyone and the really meaningful conversations that we have all had, just learning about everybody's experiences. And again, I think that just really brings more issues to the forefront that those of us that aren't actual beneficiaries but working with beneficiaries, it's just really, I think, improved care and access for everyone. I look forward to seeing Jennifer lead next year and make even greater impact.
And our other graduating member is Angelica. She had another meeting that she was in charge of up in Northwest Arkansas, so she couldn't be here. Is there any comment from her online? No? Okay. So thank you all sincerely for your years of service, and I hope those of you who have rolled on, by the way, in January, those of you coming back will have a whole bunch of new council members. We'll replace those who are departing. We'll add a few that had fallen off. We'll stay at 15. So you'll get to meet them in January, and I'm hopeful that those of you who are serving now will fulfill your 2-year term, and we can do this with you in October or November next year. So we have some MAC proposals to talk about. You guys submitted some things to the MAC at the July meeting. You'll get some feedback on those submissions today, and we're also going to talk about what we're going to submit as a council later today and what the MAC is kind of looking for. Crystal McMurtry and Elizabeth Pittman have some thoughts on that. First, they're going to present on the things that you guys wanted to learn more about at the July meeting. Then they're going to talk about how they envision this process working, and then we'll discuss some of the MAC proposals that Brandy circulated. Maybe you have some other ones of your own. So Crystal and Elizabeth, you can come up together. You can come up when needed, and we'll get into the MAC. It is 11:30. We're going to stop at noon for lunch, but it's just going to be to grab our lunch. We'll bring it back in, and if we need to work for 15 minutes while we eat, we will, since we started a little late today.
Okay, so after the last meeting, we thought of ways that we can maybe make this communication between the MCVC and the MAC stretch a little further and do a few things. So our current dynamic is MCVC identifies issues to bring to the MAC provides feedback or recommends things based on priorities, and that's more of a reactive way to go towards things, and it really doesn't allow the MAC to, get feedback from you guys, and you guys give feedback on what the MAC says. So after talking to some other states and seeing what they are doing with their councils and kind of brainstorming, we came up with a different dynamic where the DHS leadership will set focused areas based on federal priorities, program data, access rule requirements, and then you guys and the MAC will collaborate with the leadership to implement and monitor and refine those improvements. And this will create a two-way loop between the two, so it'll be more solutions oriented instead of just kind of reactive. So again, this will help us better align with state and federal priorities. It'll kind of promote measurable progress towards what the access rule wanted us to do and keep us in compliance with that. And it empowers you guys and the MAC as partners and not just an advisory group. And it, again, creates that feedback loop, so you guys are also working together as partners. But I did want to address some of the questions that you had. I'm going to let Elizabeth take care of that, so you guys do get some answers to what you wanted to bring. Have much to say. There it is. No, so the primary questions were related to PASS, around the complex care, how that's being done, what that looks like, and then just around what is the current model of PASS? How has that evolved since PASS started in, I guess originally in 2017 to today? We know it went from just a care coordination to a full risk managed care, and it has evolved over the years since 2019 when it went full risk managed care, to make sure that we're addressing the needs of the population as those needs change or are better identified. So, just what does that look like now compared to how it started? We have taken that feedback. We do want to be able to address those questions, but we're not ready to do that today. So there will be a presentation on that coming up, and I'm sure that Paula will be very influential and instrumental in said presentation. So, but do want you to know we heard that, we took those things, and we are going to work on bringing that forward for you. And just, is there anything else, Crystal? Oh, yep. All right. So then, total care plans be eligible to receive up to 40 hours of overtime and pay. I should have brought a slide deck. I'm trying to read. To help with staff shortages. So we also took this back. We discussed with leadership. We're not going to be able to do anything with this right now, unfortunately, because of funding. But that's where we are. We did note it. It is on a list, but that is kind of where we are with that right now.
Okay, before we talk about future MAC proposals for this afternoon's meeting, is there any questions or comments regarding what Crystal and Elizabeth have just shared? Everything makes sense? Okay. All right. So then let's move into Brandy's email and other ideas about things, and this is a discussion amongst yourselves. I'm just the moderator. Things that you would like to propose to the MAC. And also, Elizabeth, I don't know if you want to address this, but sometimes ideas are for the providers, which the MAC is made up of providers. Sometimes ideas are for the agency, like when it comes to notices or things that the agency does. How should they differentiate their ideas or because they can advise the agency as well as the providers. How can they differentiate in this discussion, where to send these ideas or suggestions they have?
Sure. So that's something that you guys can discuss amongst yourselves and decide if there's a particular input you want, or you can ask us if you think that it's something that providers would have input on. Taking Brandy's list, which I know you're going to discuss, there are some items on there that are appropriate for providers, like the autism things you have discussed. Other things like notices that the agency sends, providers aren't going to be able to influence much, but those are definitely things that we want to know about and to be able to take your recommendations and consider and be able to come back to you guys with feedback. So, that's kind of the different. If it's really administrative, it's probably going to be more us. If it's more like, what does the clinical practice look like? What has your experience been with authorizations? Do you have good or bad experiences? And keeping in mind what Crystal said about we want a feedback loop so that we're getting the best advice from both the beneficiary receiving the service and the provider giving the service so that we can make those policy recommendations.
Okay, so Brandy, I'll let you lead this discussion, and some of you probably have ideas that aren't on Brandy's list. That's fine. We could talk about those over the next half hour, 45 minutes as well. So Brandy can lead a discussion, but the goal is to come up with some ideas or suggestions on ways to improve Medicaid for Arkansans, either through the provider route or through the agency route.
Did everybody get the email last night? I don't know if y'all had a chance to review that. Obviously, the first one is going to be an agency question or suggestion about the delayed notices of action with the 10-day response window. We talked about that. That's been an ongoing issue because with the Postal Service, things are taking 10 days or longer to arrive by mail. And then that delay eliminates the beneficiary's ability to respond in time, and then they end up with an interruption in coverage or services. Obviously, that can be eliminated. What they were talking about earlier about the email, if you get an email stating that you have a notice to read in Access Arkansas, you can go on there and you don't have to wait for that notice to come in the mail. So that's obviously going to be an agency thing, not something we would take to MAC. Same thing, I think, with the lack of notification for scheduled appointments. That's going to be an agency thing too. The SNAP case example, I think that Amy had provided for us on that's going to be an agency thing. The delays in autism diagnostic testing, we kind of heard a little bit about that a few minutes ago. So is that something that we still need to address, or was that covered? Was that going to be covered?
And this is just a question to Elizabeth. And I know we have someone that represents the providers on the MAC. Is that something, I just want us to be appropriate as we go forth in those discussions. Is that something that we should discuss with them, like what their experience is on that side of the house and how we can loop? Or is it just something we need to leave with you, Paula? And
Thank you for respecting our rules about our online viewers. They need to be able to hear us.
You can go first if you have that.
Yeah, I mean, we could do. I'm trying to think of the best way to approach that, Amy. So you're basically asking if we would want to have like access conversations in the MAC instead of in addition to whatever. I mean, we're going to have some discussions as well, but yeah, is that more appropriate to talk about some Medicaid access?
I don't know if you saw the email. And to me, the ask, if you're talking about the one that was on Brandy's email, is more related to sort of the practice and of the diagnostic and the wait lists, which aren't necessarily something that is entirely within DHS's control, I would say, just reading that. So I do think it's something we could at least have that discussion with them on. I don't know, what they'll have back for us or if there's much that DHS can do, but it's definitely a concern. And so I think it's worth bringing to them to see what their thoughts and ideas are.
Okay.
Okay, so there's one idea that we can discuss with the MAC today. Any others from the list or elsewhere?
The last one that was on the list was the delays in authorization for DME and environmental modifications. So is that something that would go to the providers or?
Yeah, Elizabeth has a question.
Yes, ma'am. I did want to know if you were referring to delays with fee-for-service authorizations that are going through the traditional Medicaid side of the house or more through the PASS. Because those are two different kind of areas. And so I just, my shop controls the fee-for-service authorizations, but not PASS. So
it was the PASS for the process it takes to get DME equipment approved.
Okay. So then do you think that's something that should go to the MAC or something you guys should look at?
Yeah, I think that one we can, definitely do with the passes or do a study on that of what is the issue there. So we can take that one back to our group.
And I will just say there are urgent or expedited reviews. They're required under managed care and they exist on the fee-for-service side, but the provider does have to mark it as urgent so the reviewer knows.
Okay, so I hear 3 are going to go to the agency so far.
Right.
2 to DHS, 1 to, and then 1 to the MAC so far. And we don't have to bring a certain number of things to the MAC. I've tried to limit it to maybe 3 or 4 just for time purposes, but you could bring 1 if that's all we have.
I have just a follow up about the DME and the passes. That one of the things we talked about, and Jacqueline, don't let me I know that you and I talked about this. There's the pass through items for waiver, and there's DME. I think we were wondering and wanted to ask the passes about the turnaround time of how long they have to process that. And I'm speaking more so of some experiences on the provider side, the processes and protocols, and why the criteria are different from your criteria in some ways, especially for the environmental modifications.
Did you hear that? She's asking about the criteria, the differences in the criteria from the PASS for DME. Fee-for-service doesn't necessarily pay for environmental modifications outside of a waiver, so I just want to throw that out there.
The pass-through, Paula, the
DME authorizations and the different criteria.
And the turnaround times of how long they have to process those.
I don't have that off the top of my head, but I mean, I don't know if we bring that back to this group or again, it just comes back to what are our rules around that we talk about within the agency and with the passes.
Because we have a past representative that's the chair of the MAC, and I just wonder if she could give some light into kind of how that works.
I would. She is the chair, but she's only one pass, and so I would really prefer for it to come from us. So we can and she can talk about what her pass does, but she couldn't talk about what we require all passes to do.
So if I'm hearing your question right, is there a deadline when you make a request for a medical equipment? Is there a time frame at which they have to respond or act? It sounds like.
And
do we mandate that to the passes, and if so, what is it?
Yeah, and that's what I'm saying. Off the top of my head, I don't know the auth. I mean, and I think this is applicable for all. I think that with the Transparency Act, there was an act that it is 72 hours for any request has to be processed.
Any non-Medicaid entity.
Yeah.
You don't have to follow that. Please don't put that on us.
Yeah. So so there's a standard for every service. Now, what happens is a request can go in, but if the provider doesn't submit that request in a way that supports the necessity for that, then there may be questions that come back. Then there could be an appeal process. So it's as it stands, but they are supposed to, for non-emergency, 72 hours for each request.
It has to be complete.
Yeah.
To Paula's point, the request has to be complete. So if anything's missing and it's what we call pended, it's not going to go within that 72 hours. That doesn't start counting until it's complete. So just keep that in mind.
I had an example of that. Someone contacted our office because they needed a wheelchair. They live in a rural area. The wheelchair they have is good on sidewalks, but they're on gravel all the time. So they wanted a wheelchair with gravel, but they didn't have the physician's support that was medically necessary to get that specialized wheelchair, and they were having to go, or it was out of date. They got the report maybe a year ago from a physician, and they needed a more recent report. So to your point, it was a incomplete application. They were requested to provide more information. I told them what they needed to provide, and so the process is ongoing, but it wasn't acted on because it was an incomplete application.
See, I turned in all the necessary documentation, but and I even got my doctor to update letters of medical necessity, but it's been over a year, and I'm still waiting for approval.
Through your pass?
Yes, and that's with the bids in motion and everything, so.
So we look at that individually, We'll look at your case individually, Jacqueline. I'll get the details.
I was just going to suggest, I read something literally this morning about that specifically because I was looking it up, and it said some of the codes for approval that they submitted under had recently just changed, like within the last couple of months. Even like I just saw something that was a week ago. So is it possible maybe that somebody is billing something wrong, like when they're sending in the request, and it's immediately just getting kicked out and denied? Because that's happened to me with something else, not related to equipment, but with some other thing. And finally, I realized I searched long enough. It said this code isn't valid anymore. And I told the doctor, and he said, "Oh yeah, they changed those. I need to start using the new codes." And then it went through.
Yeah. So there's a
That would be real sad if that was the issue, because somebody should be figuring that out.
Yeah, so I think there's an auth request, right? So that the code changing wouldn't hit on the auth request. And what you're talking about would be a claim that got rejected. And so generally when a claim is rejected at the pass level or even at the Medicaid level, I mean, there's something goes back to the provider that says your claim's been rejected. There's a code. Yeah. And so then there's a reason for that, and then that provider who does that will, make sure that they're updated on the codes. So, and we always send out all of the, through our MMIS system, there's something that goes out for codes.
Oh yeah, we do. So we do quarterly code conversion. I can get real nerdy about this, but we do send out what we call an official notice to providers, and then we can target provider types, and we do that when we know, like if it's a wheelchair, we know we would target DME providers and physicians to make sure that they knew about that code change. So we do all of that, and then both passes and fee-for-service have phone numbers you can call. I know, to speak on behalf of my utilization review nurses, if you have any trouble with a claim, to use an example of a wheelchair again, we had somebody looking to get a wheelchair. They could not get it approved. They had not had the home inspection, which turns out that the home they lived in could not support the wheelchair they were trying to get, and it would not have worked. So you do have to do these things. They're important. It's not that we're trying to just put extra steps and barriers on there. When that was explained to him, he understood, and they were able to move forward. So they're really good about explaining to you why something is there, maybe what's taking so long, what we need, and my nurses will even reach out to the provider if they can for you to try to work that out.
Okay. So I guess, Brandy, make a note about the question. We can refer to the agency. We're more of a time issue about what we're going to talk about with the MAC. So are there any other ideas for agency or MAC? Yes, Catherine. Yes.
Has anybody ever considered having a group like this that holds maybe not just the pass system, but passes and long-term accountable? Like, because a lot of our issues are to do with that, and the pass, just in my short time of being in one, is it making me not want to apply for services for my other two children because it's such a nightmare.
I'm going to let you guys, I know there is already a pass member group that does some of that.
Yeah, I'll let Paula speak to that. So the agency has what we call an ombudsman, which is a super fun word. But we have that for everything, long-term care, pass, all of them. And that's exactly what they do, is they're there to take your complaints and help work through them. The people that you see here oversee those ombudsmen too. So if you are having trouble getting through to that line, call us, let us know. I'll let Paula speak to pass member advisory boards.
So yeah, that ombudsman, we have a provider ombudsman and we have a past member ombudsman, and that's all they do all day, every day, is they take those, they do the research, they get with the pass, they get with the provider, they get with whoever they need to make sure that they understand why that's not happening. Jason sends those to us a lot. So, and then each pass does have an advisory council made up of members of that pass. So, not one collective for all.
Get other things approved. Why is one better with more support, high support need cases? Why is one pass better if you have a lot of mental health stuff? That shouldn't be like, I don't know.
So,
where I'm at right now, I can't even get my adult son in therapy because his pass doesn't have they're not in network. I have to drive 45 minutes to get him. That's kind of crazy.
Yeah, and I think that's why it's important. There are very specific requirements for each and every managed care organization, each and every pass. So there's a standard, and then they've each, because they are different, have kind of specialized in some areas. And that's why it's really important during open enrollment to be able to pursue going to another pass. So we're in open enrollment right now. And so I think that is, some decisions.
But I'll have to lose a major, like the only thing the pass is actually covering right now for my son, I would lose if I switched to another one.
So they're not making out-of-network payments for anyone?
No.
Okay. All right. If we want to do an individual conversation about that as well.
Okay. Yes. Oh, we have one from online. Crystal?
Angelica asked, are there any updates about the impending SNAP interruption, and is there any initiatives in place to help beneficiaries?
All right.
Just briefly, I'll share, we put out a release last week about SNAP and the impact of the shutdown. So long as the shutdown continues, there will not be funding for SNAP. So, at last check, it was still going on. So we do not expect there will be November benefits unless something changes to release that funding. SNAP is 100% federally funded. So we did put out a release with some links to services out there, food banks around the state, encouraging people to reach out to family and friends. We know that that's not enough. It's a big loss. SNAP is more than $40 million a month in benefits. But we are unfortunately in this position where we rely on that federal funding, and at this time it is still locked up.
Does this affect Medicaid or it's just SNAP?
So right now it's just SNAP. Medicaid funds are loaded quarterly, so Medicaid programs are largely good through the end of the calendar year. So if this were to continue, there will be additional impacts, on different parts of our agency. But right now, the big impact that's looming is the November 1st SNAP. WIC is actually managed through the Department of Health, so I don't have all of the details in it, but I do know there was some additional funding that was applied toward WIC, and the last I heard, it was going to be good through mid-November, but that's not so far off either.
When y'all were talking about the PASS and the open enrollment, do they have the same type of assistance out there for people to find, that they can talk to help them select the right PASS program if they're not, because I'm not familiar with the PASSes at all, so I'm guessing that they're not all encompassing like other health insurance on the marketplace is. Like, you've got your medical and your dental and all that. Are all the PASSes different because she's saying she's not getting?
No, the PASSes all have to have coverage for all Medicaid services. Now, we do carve out certain services, so there's some carve out for dental, but it's a comprehensive service. So you still have a Medicaid card, but they are the payer for all of the medical services, all of the behavioral health services, all of the DD services, and anything else that's needed. So, and then open enrollment, we do contract with AFMC actually, and there's a call line, and they are able to help people walk through that.
So like Catherine's issue.
So I live in Hot Springs. St. Vincent is out of network with my son's pass. Okay? And that's where all of the therapy services for him are offered because he is 22. But he only got physical therapy for 12 units covered through actual Medicaid because CareSource is not in network with St. Vincent. And they have OT and speech downstairs, but that is through Empower and through Arkansas Total Care. So how can I be with 3 passes? Or I have to drive 45 minutes to get him therapy. And then
you're saying for the other passes that do cover CHI St. Vincent's, there's something else that they don't, it's not in network with them?
So I guess I need to call around and see who's in network with St. Vincent. But I would lose supported living hours.
Because the supported living provider is not in network with?
Well, no, because he's on the wait list. So that's my other issue. There's no cheat sheet for when you're not actually on the waiver, when you're on the wait list, and when you're over 21 and not in early intervention, whatever Medicaid. Because technically the only thing that he is getting covered by his pass now is supported living hours. And I'm just getting a bunch of harassing phone calls from a care coordinator who wants me to fill out paperwork that's not necessary.
So, I think we need to have this conversation offline because it seems like a just a singular. Yeah.
Yeah. My question was just, can AFMC help someone like her?
Absolutely.
They can call that number and say, my kid needs this, this, and this, and we live here. And then they can say, okay, this pass offers.
And so the question is who's in network, right? Because these are network adequacy decisions. So each pass has to have an adequate network, which means that they have to have coverage for primary care, for hospital, for
like all kinds of things. Everything has a network adequacy. So they each meet network adequacy or under a corrective action plan for network adequacy, but they each have to have network adequacy. So, so there may be other providers in the area that can meet that network adequacy requirement, but you could say for that pass, what is the network adequacy? What is, start with your provider and say who's in network with this pass.
And Paula, it's not just singular. I'm on the Understanding Arkansas Medicaid Waiver Facebook page. This comes up all the time about the wait list and the network. And
so let me quickly address the wait list. All right. So before pass, when you were on the waiver wait list, you got 0 services, none at all, right? Because you're not on the waiver. You got 0 supported living services. We could not provide supported living services. So you just had to wait for years to come off that wait list and go on to the waiver before you could get any sort of waiver services. So now we've been able to get this into a place where you're in the pass. The pass can give you some waiver services. And that is just, it's basically really stretching kind of the rules a bit. But because it is stretching the rules a bit, and maybe there's a better way to say that with the Centers for Medicare and Medicaid Services, because the way waivers are set up, unfortunately, is waivers are based on the number of people and it's based on money, right? So the state has to show that they have enough money to pay for a slot. Right? So there's only so many slots because it's based on the Medicaid dollars that are coming in. And you probably could explain this better than me. And am I doing okay? Okay, good.
And I didn't mean that. I'm glad we're getting services. I meant that we don't know, parents across the passes, who offers what, because it's a little, and it's so different all over. I don't know what
who
they
offers
offer.
what for waiver wait list? Is that what you're saying?
Right. That we don't know what
I'm just trying
services.
and that's what I'm trying to get to, Amy. And so because we don't have a standard, right, of saying, we can't say as a state, because of the way the waivers work, we cannot say you must offer this much service for a waiver wait list beneficiary. We can't say that because that's not something we can say as a state because of the way waivers work. So I think then it becomes, for the passes, they can say, okay, for a wait list beneficiary, how much service can we provide, how much service is needed, how much services, and so we have to leave that up to each pass, and I think it is done because it's wait list, just like anything else that's done, is on a case-by-case basis. So there's nothing we can put out there to say, waiver wait list gets 100 hours of supported living, and that's not across all the passes. So that's just kind of a conversation with each pass, and we have to allow that, and it has to be individualized.
Because they're not getting the full payment as if they were on the full waiver.
That's right, because we have not identified them. We as a state have not said you have a waiver slot, which waiver slot guarantees you access to all of those services. And so the way we've set it up with the pass is, one is the passes, we get additional funding basically through what's it called? So we can the insurance. I'm drawing a blank. It's the funding that we're using.
Match funds or
The tobacco?
matching funds or something.
No, I'll come up with it, y'all. I'm sorry. I'll come up with it. It's the premium tax.
Oh, the premium tax. Yeah.
There you go. I knew I'd come up with it. So the couple of things that we've set up in the state, because again, back before the passes, is you were just on the waiver wait list. That was it. We could provide services for waiver, and you were on the waiver wait list. With the passes, a couple of things happened because we used a managed care, and I know there are issues with managed care, as there are in every state with every managed care program. But they have to pay a premium tax because they're an insurance product, and that premium tax is used to buy new slots on the waiver. So we've got that income being generated, so that's a really good thing. And then it gives us some limited flexibility in being able to provide some services to people on the waiver wait list while they await going on to full waiver.
Yeah, I think your biggest issue is that people think on the pages, and they hear from other people, parents that are getting this from this pass, and they think they should get everything. See, I didn't know the history of you didn't get anything. So, but I think it's the traffic that goes on the pages. I just wanted to briefly go back to
Hold
the
on, we're going to
Medicaid.
take a break there. We're going to get our lunches, and we'll come back in here and continue the conversation because we're going to have the MAC folks coming in at 12:30. So everybody get your lunch, come back in. We could continue discussing until 12:30.
I just want to ask Paula about, I know we have those consumer advisory councils on the passes, and I want to speak from two perspectives. One, having worked at the pass, it was so hard to recruit people to get them to come. So we would have literally out of, I don't remember how many members we had in Empower, probably 15,000, maybe 5 people that came. But on the side with a pass, even with Summit, I don't even know when those meetings are. Like, I haven't been notified. I would love to participate. I would love to see if we could solution together with you guys, Paula, a way to link this group back to, I don't know who brought that up, but to link the two so we could have increased participation and voices. And I don't know if it's because, no offense, because you guys are at the Consumer Advisory Council and members think they can't say anything. I don't know why it's such low participation, but also we needed more variety of members at those meetings, which was hard to recruit. So I don't know what the passes recruitment, I know what ours was, but on the side of being the mom of a member, I haven't heard anything about that from Summit, and I know they all have to hold them. So
I mean, as
just
an
wanted to-
agency, we just have to require that they have one. We can't really tell them how to run it or.
Yeah, and they each should have, thank you, Rob. Yeah, so I think we do require, but I mean, if we need to go back and make sure that they are doing it as intended, right? If they're only doing minimal coverage of that, or if they're doing it as intended.
I just wondered how we would know, because I haven't found out through Summit about how would we know, just as a general member, that to participate in that. Are they, like, we would call, are we calling all the members, or is there somewhere posted that the pass is posted? Because I haven't heard that there is one. I don't know how often that they are anymore, but it would be great for everybody to know and to link it, maybe post it on Medicaid Saves Lives, hey, Summits is this time, or see, I just don't know how that works, even having been involved in a pass. Maybe that's why there's low participation, because not everybody knows there's a voice or a way to participate.
Yeah, okay.
Is that something to bring up to the MAC? Is there past members who could maybe speak to, this is how often we have these meetings, this is how we notify our members?
I can bring somebody back next time to talk about consumer councils or advisory councils from the pass office. I'm happy to do that if you want to put that on.
Okay.
Because like y'all said about I don't know how to say the word, the ombudsman's office.
Ombudsman.
Yeah, so I've called them multiple times and they've helped immediately within like less than 2 days, but I didn't know the answer to any of my questions. And then if I had the problem again with my other son later on, it'd be great if I could just approach it the correct way so I don't have to go through him not getting services and all of the hoops.
If any of you, and I've talked with Jacqueline about this, I'm going to put her in touch with the Summit Pass Ombudsman to help with her problem. If any of you don't know who the Ombudsman is or want the contact information for your Pass's Ombudsman, just reach out to me and I can get that for you and put you in touch with that individual. Okay, so we've got 2 MAC proposals and a couple agency proposals, at least 2 agency proposals. Is there any other things at this meeting that we would like to discuss or consider for either the MAC or DHS as an agency? Or do you just want me to shut up so you can eat your food and I'm not going to eat my food? Okay? All right, sounds good. I want to thank the DHS leadership, especially Paula and Elizabeth, and Mary had to leave and Jay had to leave, but I always appreciate them being here. I know that they have very busy schedules, and now that we've added a MAC meeting on the tail end of an MCVC meeting, we only have 4 instead of 6, but it is a longer day for them, so I appreciate their attendance and participation, and I really don't know how these meetings would work without the division directors who agree to come and share their knowledge and expertise. So if you guys have any other questions, even as alumni members, my email hasn't changed. Contact me. I can get you answers. I can get you in touch with the people who will have the answers. And just appreciate you all being here, especially on a dreary day. Drive safely after for those who's staying for the, I know Amy's staying, Brandy's staying, Jennifer's staying, and, okay. But as participating members, the three of you are our participating members today. So, and we will, let's see, I guess we need to decide who's going to, we need to actually decide well, no, the co-chair will stay on at the January meeting, but we need to see if there's anybody interested in staying on for the January meeting as the MCVC representative. For example, it was Jennifer last time, it's Amy today. We need someone else, if you're interested, to stay on and be a representative for the MCVC at the MAC meeting in January. Any takers? Returning members only. Okay. Lakeisha will be our returning member, and then whoever they elect as co-chair from the new members will be the third representative. Also, any objections to changing the language in the charter? We discussed it over email regarding participation at meetings, attendance at meetings. I didn't see any objections to what I proposed, so if everyone's in favor, I will change the charter and make those changes moving forward. Good with that? Yeah. Okay. All right. Thank you all. Enjoy your lunch. And if you can, wrap up in the next 10 minutes. We'll have the members of the MAC coming in to eat, and they'll need some tables, although there are some empty spots.